Hey everyone, welcome to Clinical Simulation Review. Appreciate you joining us. Today we're going to discuss a cardiac patient who's been admitted to the intensive care unit. He's 58 years old. He has a history of diabetes and mild heart failure. He's 6 foot 2 inches tall and he weighs 81 kilograms. So before we go any further, just in case we need it later on in the CSE, we're going to go ahead for practice and we're going to calculate his low and high end of his tidal volume range that we would need to set his tidal volume initially. So we know that we take his 6 foot 2 inch in height, which is 74 inches, and we multiply that 12 inches over the base of 60 inches. So 12 inches times 2 pounds per inch over the 60 inches gives us 24. So then we take our base of 50 kilograms and we add 24 kilograms, which gives us 74 kilograms as his ideal body weight. Now they tell us that he weighs 81 kilograms, so we know that he is over his ideal body weight, and we can add obesity to one of his diagnosis, okay? So we also know that we would take our 74 kilograms and we would multiply that times 5, which would give us 74 times 5 would give us 370 milliliters, and then we multiply that 74 times 10, which would give us 710 milliliters. So our tidal volume range, if we have to intubate him and put him on the ventilator, would be 370 on the low end and 740 on the high end. That's good practice, and then you have it ready for you on your scrap sheet of paper if the sim calls for that. Okay, so we find out that he is conscious, alert, he has some respiratory distress, and he has some dyspnea. Remember, dyspnea is painful labored breathing, so he's working extra hard. His temperature is 98 degrees. His heart rate's 116. His respiratory rate is 22. His blood pressure is 141 over 96. Based on a normal of 120 over 80. So he's a little bit hypertensive. He's tachycardia with a heart rate of 116. We know that 60 to 100 is normal for an adult. His respiratory rate's a little bit high. He doesn't have a temp. His temp is normal. So far, we've just got that he's under some stress and he's working a little hard to breathe. Okay, so we're going to continue with our initial assessment in stage 1. We can see that he has 3+ pedal edema, which is one of the signs for congestive heart failure. So remember that you're going to look for signs and symptoms of certain pathologies. So it's really important that you are familiar with different pathologies and what the signs and symptoms and key words are associated with that pathology. So we've got a Swan-Ganz catheter in place, so we're going to be able to see some hemodynamics. So it's telling us that in our initial assessment. We've got an ABG, a pH of 7.32, which is slightly acidotic, below 7.35, the acceptable range. His PCO2, though, is 44. It's in range at the high end, so he's ventilating. So we know that our critical life functions, ventilation is the number 1 most important, and right now he's doing okay with that. The second most important is oxygenation. Right now his PO2 is 68 and his saturation is 91%. So we've got a little bit of a possible oxygenation issue. It's a little lower than what we want it to be, especially because they're telling us in the SIM information that he's on 55% FiO2. So definitely a concern. He has poor oxygenation considering he's on that high an FiO2. with a saturation of 91 and a PO2 of 68. We should be seeing better numbers than that. All right, so we go on to the next screen and we look at some more opportunities to assess him. His CBC, we're going to choose that. His hemoglobin is 14. We know that normal hemoglobin is 12 to 16. So he's okay there. He's not anemic. His hematocrit is 41%. We know that normal hematocrit is 40 to 50%. So he's okay there. He's on the low end, but that's okay. His white blood cell count is 7,700. We know that 5 to 10,000 is normal. So still, remember his temperature was 98.6, which is perfect on the dot. And his white blood cell count's right in the middle of the 5 to 10,000, so he's normal there. We look at his EKG results. He has sinus tachycardia, which is telling us that his rhythm is normal, but his rate is too fast. Remember, his heart rate was 116. He has some spiked T waves, and he's having some PVCs. We know from our studies that PVCs are most often caused by hypoxemia. So if we fix his oxygenation issue, then the heart may not react and send out those extra beats or PVCs to try to compensate. His cardiac output is 4.1 liters per minute. We know that normal is 4 to 8, so that's okay. His mean arterial pressure is 33, which is high. We know that normal is 13 to 14, so that's another red flag that's pointing us toward left heart failure. We know that the normal is definitely much less than 33. Pulmonary capillary wedge pressure reading is 25 on a normal of 4 to 12. So that's another red flag pointing us toward pulmonary edema and left heart failure. His CVP is 5 on a normal range of 4 to 12. So that's actually okay. It would be elevated if there was right heart failure. Our issue right now is throwing red flags toward left heart failure. His chest sound, auscultation sounds, fine crackles in the lower 2/3 of the chest. So fine crackles is another red flag, key word that points us toward pulmonary edema and left heart failure. His basic metabolic panel, his sodium is 138, which is normal. His chloride's negative 110. Potassium is 5.8, his bicarb's negative 21, and his glucose is 85. His BUN is 15 and his creatinine is 1. His diagnosis is congestive heart failure. We're going to administer morphine and furosemide. Morphine does have an effect on the heart, even more than pain relief. The most important effect of morphine in this situation is it does increase cardiac output. Furosemide, also known as Lasix, will also help him remove by urination some of the pulmonary edema and extra fluid. And our diagnosis is cardiogenic pulmonary edema, left heart failure, congestive heart failure, and he is stable, but he's distressed. So there's no emergency, but we do need to get him some relief. The doctor says, well, RT, what do you recommend? And we say, we recommend the morphine, furosemide. We increase the FiO2 to 60%. The medical resident now wants the SvO2 monitored on a continual basis and asks your recommendation. The resident wants the systemic vascular resistance index as well. So the first thing we would do to be able to monitor the SvO2 is replace the original oximetry with reflective oximetry capability into the Swan-Ganz catheter. The resident wants SVRI, so systemic arterial systolic and diastolic pressure, CVP, cardiac output, BSA. All of those can be monitored as well, and then that gives us the diagnosis, because they're all elevated, of cardiogenic pulmonary edema. And note that the mean systemic arterial blood pressure, CVP, and cardiac index is a correct way to measure the SVRI as well. So that Swan-Ganz catheter is definitely helpful for this patient. So while we're talking about cardiac patients, let's talk about normals. Remember, we talked about the pulmonary capillary wedge pressure tells us if there is adequate left heart function, and that normal is 4 to 12. The mean arterial pressure tells us if there is an issue with edema backing up into the right heart. Normal is 93, 94 millimeters of mercury. And then our CVP, central venous pressure, normal is 2 to 6 millimeters of mercury or 4 to 12 centimeters of water. Normal cardiac index tells us what the left heart function is. That normal is 2.5 to 4 liters per minute. Pulmonary vascular resistance tells us if there's a lung issue, and that normal is 200 dynes or less than 2.5 millimeters of mercury in liters per minute. The end-tidal CO2, and if we have a sudden fall, that tells us there's increased alveolar dead space and a potential pulmonary embolus. The pulmonary embolus would block perfusion to the lungs and increases the alveolar dead space and percent of shunt. So that gives us oxygenation issues. And our goal for our shunt equation is less than 10%. Okay? So this is a very interesting cardiac CSE. It does happen quite a bit, seeing cardiogenic pulmonary edema and acute CHF in a diabetes and mild heart failure patient. It's definitely one of the most common patients you will see in the emergency room. Now that is all of that cardiac CSE, but we know if we stay associated with this patient, then we're going to be looking at using BiPAP to try to help clear the CHF, and to try to use a digoxin or digitalis positive inotrope to try to increase contractility of the heart. The morphine is going to help with that as well, but if it's not sufficient, then we can look at using some other medication. We're also going to make sure we've got this patient's oxygenation corrected. It looks like the 60% partial rebreather did that for us. Keep in mind with your mask that your lower FiO2s, you can use a simple mask or a Venti mask. And then our partial rebreathers of 40 to 60% or so, we can use the partial rebreather for. And then if we need the highest FiO2s, we can use the non-rebreather for that. Now, don't let the CSE or the TMC trick you if it says that you're called to the room, because the non-rebreathers bag on the mask is deflating partially during inspiration. That's perfectly normal. It's when it's deflating completely and the sides of the rebreather bag are touching and completely deflating during inspiration that is definitely not normal, and the answer to that is always to increase the flow to the mask. So we want to turn up that liter flow, and that's going to give us our higher FiO2s, the non-rebreather. Now, if the non-rebreather is not sufficient and we still have oxygenation issues, then we're going to go to positive pressure, or we can go to hyperbaric oxygen. It's according to how severe it is. We can use ECMO at that's kind of a very, very last result, but all of these are potential cures to these acute episodes that our diabetics with cardiac issues have. So just keep those things in mind. If you have any questions, send Jana or I a inbox message, or you can just give me a text at 606-224-4568, and we will get your questions answered. Okay, thank you very much for joining us for this CSE review for cardiac, mild CHF, acute distress for cardiogenic pulmonary edema. Thank you.